Hello and welcome to Informed Dissent. This is your news of the week for the week of March 22nd, 2026. New York Langone has partially resumed gender treatments for minors following a legal ultimatum from New York AG Letitia James. In Colorado, Jefferson County was found in violation of Title IX. 61 male students on girls' sports teams, an 11-year-old girl nearly required to share a bed with a trans-identified male on a school trip. There is some light at the end of the tunnel for the folks in Colorado, however, because this November, the voters will decide on 3 ballot initiatives: protecting girls' sports, prohibiting gender surgeries on minors, and elevating child sex trafficking to a Class 1 felony. Signatures for this ballot initiative were gathered almost entirely by volunteers, and we want to congratulate Aaron, Travis, and every single volunteer who beat the odds and made this happen. In California, young people harmed by gender-affirming care gave devastating testimony against bills that would force insurers to cover gender treatments and route at-risk youth to the Trevor Project. One young man testified that when he called the Trevor Project as a suicidal teenager with concerns about the medical treatments he was receiving, they hung up on him. Both of these bills passed on party line vote. The Texas Supreme Court ordered PFLAG to hand over records to AG Ken Paxton after PFLAG's own legal filings inadvertently gave his office a roadmap to investigate doctors who may have continued prescribing to minors in violation of the state's 2023 ban. This week, we sit down with Scot Glasberg, past president of the American Society of Plastic Surgeons, and a central figure in the deliberation that led the ASPS landmark position statement recommending all gender-related surgeries be delayed until age 19. He ran towards this fight when others didn't, and we're glad he's here. On to the show.
Hi, welcome to Informed Dissent. My name is Jamie Reed. I'm a whistleblower from a pediatric gender center, and I am here today with my esteemed, lovely co-hosts.
Hi, I'm Lauren Legere, co-director of the LGBT Courage Coalition. Corey?
I am Corey Cohn. I am the human companion of Dorian the cat.
That's a great introduction. Okay. It is March 21st, and I want to take you back in time, back to February. So on February 3rd, the American Society of Plastic Surgery, which I will refer to as ASPS, issued a 9-page position statement in which they recommended all surgeons delay all gender-related surgery, breast, chest, genital, facial surgeries, until a patient is at least 19. And this was a big deal because it was the first statement of its kind from an American medical association. And what happened next got really complicated and really contentious quickly. So ASPS is not like a minor, tiny player. It's not one of the trifecta players, like in my mind either. That would be the APA, the American Pediatrics Association. Am I saying that?
AAP, American
The AAP.
Association of Pediatrics.
Yes.
The Endocrine Society.
The Endocrine Society.
And WPATH.
WPATH.
They are the trifecta holding the thing together, but the ASPS, the American Society of Plastic Surgeons, also is dealing with these guideline issues as well, and they also participate in quote-unquote gender-affirming surgeries.
Yes. Okay. So ASPS, I think, represents about 11,000 physician members, and it's international too, which is interesting because its name is ASPS, but they represent plastic surgeons internationally. So this is not like an outside criticism group like complaining. This is like one of the internal mechanisms of what's holding this up is saying, no, wait, we need to stop. And there are a couple things about their statement that was really important. One of them was they age cut off at 19. Um, they talked in their statement that the whole framework had poor evidence. So their statement is not just the surgeries and the surgical outcomes have poor evidence. Their statement recognizes the endocrine pathway itself is poor evidence. And they also explicitly are rejecting any of the suicide narratives or claims that withholding or delaying these interventions is equivalent to, pushing suicide. So their position statement was a really big deal. And what happens next is you have to go further back in time to understand what happens February 3rd and after. So I don't know how to do this. Do you want me to go back in time or do you want me to say February 3rd, this happened and then this was the fallout and it makes sense to go backwards?
Well, give an overview of the fallout really quick.
Okay. Statement is made February 3rd and really pretty quickly, 7 people send this open letter to the ASPS board, and their demand is that they want transparency or they want to know who wrote it. They want to know how it was developed. And that letter, the complaint letter from the 7 task force members, um, included. So it seems like it was spearheaded or written by Dr. Jens Berlini, but then the fallout is because Dr. Scott Leibowitz publishes this letter publicly on LinkedIn. Really interesting sidebar here, and I would love it if listeners would jump in. It seems like LinkedIn is becoming like the new social media platform to be debating pediatric gender medicine, which great. Now I have to learn how to use another platform. But so Scott Leibowitz publishes this letter on LinkedIn, and that creates even more fractures because one of the people that signed it then withdraws his signature.
Yep,
Well, can you explain
I'm
who
gonna
Scott
stop.
Leibowitz is? Because he is not a plastic surgeon.
Okay, but Corey was going to say, I want to stop for a minute.
Yeah, could you explain who Scott Leibowitz is?
You too. You're like of the same mindset. Okay. Uh-oh, hold on. No, get out of here. What do you need? No, you cannot tell me something. Go away.
Oh,
I will talk to you in 1 hour. Lauren, you're going to have to cut him.
I know.
Okay. Okay. So Dr. Scott Leibowitz is a child and adolescent psychiatrist and a WPATH board member who was serving on the ASPS's Gender Surgery Task Force. He was one of 7 people to sign this open letter complaining about the ASPS, and he's the one who posts this letter publicly on LinkedIn. He argued that the ASPS statement, quote, ignored the reality that a young person's maturity to make a decision can differ across ages. Real good child and adolescent psychiatrist there. That low certainty evidence is a reason for guardrails, not restrictions. And Leibowitz is really interesting. I would almost say one of Lauren's BFFs. Leibowitz is okay. So if you listen to the New York Times podcast called The Protocol, he has like half, almost an entire, like half of an episode where he speaks. So he previously worked in Ohio, and he has worked with our other good friend who, God, there's so many doctors. Anyway, he is of this like mindset where he's more in the camp of do a long drawn out assessment, and maybe there's a couple people to say no to, but for the most part, most people will be medically transitioned in childhood. Um, he presented at a conference that Lauren and I attended, and my takeaway when I saw him present within the past year was that he will have a conversation with you only if you agree to his stipulated point first. And that stipulated point is there is such a thing as a trans child. He will not engage you or debate you if you will not agree to core point number one, which is that this thing exists. So I find that a very challenging framework for debate because um, you're demanding belief in the structure in order to even debate all of it. So he signs this open letter to the ASPS and he publishes it on LinkedIn. And he, we find out later, so ASPS puts out their position paper, and then we find out later that running kind of in the background was this task force that they had set up, which hadn't really had a lot of public know, like people didn't really know about it.
What was this
What was
task
the task
force
force
set
for?
up to do?
Okay.
I love you, Corey.
I was there first this time.
Okay. So so this is why this is so in the weeds. Okay. We have to go back in time. So we have to go back in time to the cast report and when it first comes out. So I think a lot of people know that there were two iterations of the cast report. There was an interim report, and then there was the final cast report. I was still working in the Gender Center when the interim report came out, and then when the final report came out, it was well after I'd already left. So the cast report comes out, and at the time, Dr. Glasberg, Scot, was the president of the ASPS. And his background is interesting. So he is in private practice. He's a private practice plastic surgeon. He works in Manhattan. And he's kind of honest about this when I talk to him in the interview, but he talks about how a lot of the previous presidents of the ASPS were academics. So they were working in academic hospitals and they had done a lot of publishing and they had done a lot of research. And so I think he went into the role a little bit knowing I'm not in the world of academia, I'm in private practice. But he had this history of working with not only academic plastic surgeons, but he really cared about medical ethics and he also really cared about evidence. And he had been part of these other groups that were trying to figure out what's the best way forward for breast surgery in general. I'm sorry, I just went off on a little tangent, but so he sees that the cast report comes out and he immediately like it clicks for him like this is talking about the work that we do too, even though it's not explicitly talking about surgery. Like he saw like, okay, the evidence is poor. He knew that there was a connection there. And so he reached out to Dr. now Baroness Cass, and he started some engagement with her talking about evidence and evidence-based medicine. And he being the president of ASPS, the president has this unique historical role in which they get to invite a guest or set up a panel at their yearly conference. It's like you're the president, you get this thing, you get to pick and make a panel. And it's like, yeah, you're the president, you should get to do that. So he invites Baroness Cass to come to speak on a panel at the next ASPS conference. And the ASPS conference, they refer to it as the meeting. It's going to take place in California, but at the same time, it's scheduled to take place Something is scheduled to take place in Lisbon. Does anybody remember what happened?
W path.
WPATH. So the conferences are kind of set up to occur at the same time. And immediately, the gender surgeons who are within the ASPS, they were like, oh my God, Hillary Cass is going to talk at our conference. We have to do something about this. And so they started reaching out to the ASPS board and to Dr. Scott, and they were basically saying, first they demanded that they set up that his panel alone would have a virtual way to join so that you could interact with the panel so that they could still be in Lisbon, but that they could log in just for this panel and just to like make sure that they're engaged. And he goes out of his way to set this up. He's like, sure, absolutely. I would love to do this for you. Let's set this up.
Doesn't seem like a huge ask.
It doesn't, but like it's also time zone differences
Sure.
and
That's up for the people in Lisbon to figure out, right?
But he is willing to accommodate people who are not physically attending his conference, but attending someone else's conference. He is willing to accommodate those people by giving them a way to virtually access this panel.
But he invites, it's not just like this is not just Hillary. I've never met the woman. I should call her Baroness Cass. It's not just Baroness Cass's panel. Like there's a gender surgeon on the panel. Like this is about evidence-based medicine. And
Sure.
so he thinks this is good to go. We're going to move forward. And the controversies don't end. Like the complaining, the like, we don't want her, like, you didn't do enough kind of a thing, like, don't end. And so Dr. Scott basically makes the decision where he says, okay, we're going to postpone Baroness Cass speaking at the ASPS. And he proposes that maybe we just need to get all these people, the loudest, like most concerned people, like maybe we just need to put them in a room and we can all talk through and we can come to some consensus and then we can have Baroness Cass do a presentation at a later date.
Okay.
Yeah.
So he doesn't know that he's being stonewalled.
I think he's such a kind soul, but I think he saw the evidence and thought, we're all doctors here. We're going to engage with the evidence.
We're rational people.
Yeah. So he proposes this task force. And he will not disclose a whole bunch about what was ever said in the task force meetings, but he will disclose this. So in order to be on the task force, everybody else has to agree. Like an invitee can only be invited if everybody agrees with the invitee. That already is a big hurdle, right? Like
That's a good way to reach consensus, is make sure only people who agree with you are participating.
Yeah.
okay. So this is who so now I want to tell you, I want to share with you who is on the gender surgery task force. So we'll start with Dr. Lauren, I don't know how to say his last name, Schlelster.
Okay.
Okay.
The incoming president of WPATH and one of the key witnesses in the detransition case that ended up with a $2 million award.
Yeah. You know it. Okay. So we've got Dr. Lauren, President-elect WPATH, becomes a member of the ASPS Gender Surgery Task Force.
Okay.
He is the medical director and of the Gender Affirmation Surgery program at Rush University in the Medical Center in Chicago.
Rush University, that means that there's no waiting period before you can have your parts removed. Is that what that means?
Okay. So
I don't know. I'm asking.
No, but
okay.
So a couple things just to add on, Corey, you're absolutely right. He testified in Fox Varian's malpractice trial. He testified and admitted in that trial that surgery is not a mechanism to prevent suicide. which, by the way, is a position that contradicts a sworn statement he gave in a 2022 Florida case involving a minor. He signed that task force open letter that Leibowitz ends up publishing on LinkedIn. And he was part of the group that pressured the ASPS board regarding the CAS review panel in 2024. Okay, so he's on the task force. Dr. Scott Leibowitz is on the task force. Leibowitz, like we said, is a board member of WPATH. He is not a surgeon, but is a psychiatrist.
Right.
Um, okay, so then the other individuals on the task force. So now we're going to add a couple names that I don't know if people have ever heard of before, but Dr. Asa Radix.
I've heard of that Asa Radix.
Asa Radix. Okay. Asa Radix.
Urologist, is that right?
No.
Keep going. I might be confusing them.
HIV doc, I
Oh,
think.
okay.
Like was working in, I think HIV care.
All right.
I think I'm gonna do something because I think it's relevant. Dr. Lauren is not trans. Dr. Scott is not trans. Dr. Asa is a woman who I think identifies as non-binary.
Okay.
And is a WPATH, was a WPATH president.
All right.
So she got herself on this task force. Another individual on the task force is Dr. Jens Berlini, a Swiss-trained Johns Hopkins residency plastic surgeon who joined Oregon Health and Science University in Portland, their transgender health program in 2016. He specializes in phalloplasties and gender affirmation facial surgeries. Berlini, it appears is pretty clear, was the letter's primary author. He and pink-haired Blair Peters are colleagues at OHSU, and they're
Yeah.
frequent research collaborators. Guess what? He also is a member of
Yeah. And
WPATH.
WPATH.
you mentioned Blair Peters, who has made the social media rounds before as one of the examples of the extremist doctors in this whole thing, because he looks a little bit crazy, but also some of the things that he said are, let's say he has a very left view, progressive view of medicalization. I think that's fair.
Corey, do you think he's cute?
No,
No? Oh, okay. Not your type.
no.
Okay. Is it the pink
What?
hair?
Yeah, I mean that's pretty damning.
Okay.
Maybe a little salt and pepper gray hair is okay, but not pink.
Okay. So Dr. Blair Peters is also on the task force.
Yeah.
No, wait,
So
he's not on the task force. Sorry.
Okay.
But he is on the ASPS Gender Surgery Committee. He is an ASPS member, and he isn't on that 7 people letter, but he spearheads this much larger complaining list where he gets a bunch of signatories, like 268 signatories, to also complain about the ASPS position statement.
Right.
But he was publicly critical of the ASPS position statement, posted on threads about it in the days following its release. And he was one of those members who sent the letter demanding the virtual attendance accommodations for that potential CAS review panel.
Yeah.
The other individuals here are Dr. Melissa Poe, board certified plastic surgeon, head of the transgender surgery program at Kaiser Permanente in LA.
Is this a male or a female?
It's a female. She is the chair of the ASPS Gender Surgery Committee, with Blair Peters as her vice chair. So this makes them the two most senior ASPS members in formal governance oversight of gender surgery. She's
All right.
published extensively about gender surgery techniques. Um, she may be on the ASPS Gender Surgery Task Force, but we could not confirm that. So we know some of those who were on it, but we couldn't confirm all of them. And then one last doctor to talk about. So Dr. Rachel Blue Bond Lagner is a plastic surgeon, ASPS member, and she worked, see, I want drum roll sounds. Are you ready? She worked running the NYU Ligon program, where she and her team performed over 800 gender affirming procedures annually. And guess what's going on at that NYU program like right now in the news of the week? New York.
They're
They're
going back
stopping their
and
services.
Well, okay, so
they got
who
sued, right?
they basically got a cease and desist like no from HHS. 2 weeks after the ASPS position statement, the hospital shut down its transgender youth health program entirely, citing the Trump administration's threat to withdraw Medicaid and Medicare funding. So
And then
then
the state
it is
attorney general got involved, right?
exactly. So then the state attorney general sent a letter saying you're breaking New York civil rights. There were protests out front of her hospital. There were demands from 73 New York legislators ordering that the decision be reversed. Then, like you said, the attorney general demanded that they reinstate. So she is also right here in the mix of what's going on for the ASPS, and an ASPS member and on that surgical team. So these are all these key players. And then I'll add tiny segue, but yesterday a judge, I believe in Oregon, ruled that the HHS push to get these places closed over funding. That judge, a Biden appointee, is basically trying to argue that that is against the law. Okay. So the task force gets set up because of the Hillary cast fallout. And in the interview where I talked to Dr. Scott, he will share what was the point of the task force? Why did it get set up? I think the most critical thing about this task force is that these are not all ASPS members. They don't write ASPS guidelines. They're not on the board. These are
They're
WPATH people,
they're experts. They know all about this topic.
but they're all WPATH.
Oh, you're saying they have a conflict of interest.
Yes. And the gender surgeons themselves have a conflict of interest.
And what's their conflict of interest? This is a professional society, right?
I'm
What,
sorry, yes, but if your whole job and everything you've ever published or written on and everything you've ever done in your career is about the type of surgery that they are saying there's no evidence to continue to do, that's the
who's there's other surgeries that are cosmetic surgeries that don't have benefits. So, and it's the plastic surgeons that do those. So what's the message that, like, for us, we're outraged, right? The plastic surgeons whose job it is to put a scalp in somebody else's flesh and then pull their skin back and do something underneath it. That's what they do. I know you flinch. That's what they do. From their point of view, what are
Right,
they?
but plastic surgeons are not supposed to, they may adjust cosmetically, but you cross the line in some of these surgeries with, you're actually harming the functioning of the body. And I don't know that other plastic surgeries are allowed to cross that line where they actually remove functioning from a healthy body.
I guess it depends on a number of factors, right?
Yeah.
And this is where the ethical debate happens. Because from our perspective, there's no upside, but there are people who claim that there are upsides. And so, from somebody who is coming into this without having a lot of premises already set, a lot of assumptions already made, they are going to ask the question, is there more upside than downside? They're not going to just take our word that there's more downside than upside. They're going to ask, how does this work out? But the problem is that, and here's where I would say where the conflict of interest is. You're assembling a bunch of people who have a financial incentive to only reach one conclusion on the question. And really, their calculus is not, is this good for on net, is this better for patients or worse for patients? Their calculus is on net, is this profitable?
Mhm.
Are we more likely to end up being sued so that we lose money and over immediately and over time for this? Or is this better set up so that we can do these procedures for a profit? That's the question. Now, that has to do with patient outcomes. And it also has to do with how likely it is that any previous patient can effectively bring a legal complaint against any of the procedures that have been performed. So I can tell you that if the statute of limitations were closer to 10 years than 2 years for these procedures, then they'd reach different conclusions. They're not going in to figure out, is this good for patients? They're going in to figure out, is this okay, still okay for us to do?
But you point to fiscal. I always chafe at that a little bit. I still think so many of these providers, they would be making money either way. Um, I think that this specific type of intervention is so much more belief driven. Like I don't know that Blair Peters would make money being a plastic surgeon either way. I don't think that he makes more money necessarily because he's this kind of plastic surgeon. I think that the reason why he is willing to do nullification surgeries is because it's all belief driven.
It's not all belief driven. Somebody's got to buy the yacht.
Or the pink hair dye.
Yeah.
Okay. So then I'm gonna, can I bring us up to like what happened in the New York Times on March 16th?
Let's.
Are we up, did you follow all of that?
I think so.
Okay. Lauren,
Yes, go.
you're with me. Okay.
Yes.
So then on March the 16th, another element to this story gets brought to light by Jeremy Peters, who is an interesting writer. He's a New York Times writer, and he's a national reporter who focuses on free speech and the politics of higher education. I think
Okay.
it's interesting he's crossing over. He's coming over to the trans world here.
Okay.
He writes a piece where he adds this element, which many of us did not know. But apparently, last winter, well, I mean, over the winter, we're just coming out of it. I I cannot believe I have to say this. Dr. Oz,
Okay. The TV host.
yes, Dr. Oz, who's now the head of the Centers for Medicare and Medicaid Services, apparently brought all of the leaders of the country's major medical associations into his office for what he called a grand rounds. So he had the ASPS lead come in. Dr. Scott was brought. The AMA, the American Medical Association, the American Psychiatric Association, they were all brought in on one side, and he wanted to discuss with them the data and the evidence for transgender medical care for teenagers. That was like the topic. And I guess on the other side, I don't know exactly who was representative on the other side. I know that Segum had a representative in the room. It sounds like Zhenya was there. And the goal was to basically ask these leaders, why haven't you followed the evidence? Like,
Right.
why is it that we're having to intervene at the federal level when the evidence is clear for everybody to look at? Why haven't you just updated your guidelines? And apparently, he had all of the medical associations and societies take turns in the room defending their guidelines. And the medical association that he had go last was the ASPS. And apparently, this was before their policy statement was released to the public, but the ASPS said in this private meeting, they said, we are changing our position.
Wow.
Coming out because of the limited low quality evidence and that they are flipping. And apparently, that meeting was when I guess the AMA has since announced that they're also kind of hedging with the ASPS and saying basically if the ASPS, the surgeons say we don't recommend the surgery, then AMA agrees with the ASPS. But neither the AMA would not talk about endocrine. The American Psychiatric Association continues to support. In the article, the New York Times said the association's chief executive said that they are relying on, quote, the best available evidence and expert consensus, saying that they still support this as a way to reduce the risk of depression, anxiety, and suicidal ideations.
Expert consensus.
Yes.
It's a bunch of old guys around a table.
Or a bunch of gender surgeons from WPATH around the table.
Sure.
Yeah.
But this article came out, and Dr. Scott Glasberg is quoted in this, and he talked about the evidence. And when this article was talked about on Blue Sky, they were very unhappy about the way that the article ended. Which is basically an argument saying that, I mean, the final quote is, I'll just read the final two paragraphs. Quote, I really worry that professional medical organizations are mortgaging their credibility on this issue. Says Kathleen McDevitt, a psychiatrist at Baylor College of Medicine, who made a presentation at the meeting and who has co-authored several academic articles critical of the evidence for gender-affirming care. We should reach out to her. We should talk to her. She said, quote, I want people to be able to trust our institutions and our professions, she said, and I also want us to be worthy of that trust. So that is kind of like all of the backstory. And then I spoke to Dr. Scott and we have his interview.
All right. Well, let's roll it.
Do you understand, like, do we think that the back is all explained?
Yeah, let's see the rest.
Okay. Well, then let's roll it.
Roll it.
Welcome back to our interview portion of Informed Dissent. I am here today with Dr. Scott Glasberg, and we're just going to jump in. I want to start really basic. So, for listeners who are not familiar at all, what exactly is the American Society of Plastic Surgeons?
Sure. The American Society of Plastic Surgeons. Oh, by the way, thank you for having me. The American Society of Plastic Surgeons is the largest plastic surgery specialty organization in the world. We have about 7,000 members in the US and about 11,000 plus globally.
Oh,
Um,
so you're outside the, okay, excellent. Okay.
all of our members are board certified plastic surgeons, which means they attain a certain level of expertise and skill through testing and training, which is important for people looking for plastic surgeons who are well qualified, well trained. And we are a organization whose mission is in the interest of science, data, evidence, which I guess we're going to talk about, but also patient safety and patient well-being. What we do, we have various divisions of the society. Some a lot do education. We do a lot of research under the Plastic Surgery Foundation, which is the charitable and research arm of the foundation, which is the one that I was most recently president of. I've been a president of the American Society of Plastic Surgeons in the past. So we do a lot of elements research, education of our members, of the public. We have public facing elements to it as well, and attempts to bring as much information to the public as possible. We would like to think of ourselves as the leading resource of information for the public when it comes to plastic surgery issues.
Can we go into a little bit? You mentioned board certified plastic surgeons, and you mentioned that they do some testing. Can you explain, this is after somebody goes through their general training, they're a surgeon. What are those extra steps that they have to go to for that board certification?
So it is indeed a lengthy process. So we go to med school first for 4 years, and then we do training. There's a couple of ways to get to plastic surgery to eventually be plastic surgeon. You could do as I did. I did 5 years of general surgery training first, and then transition to a plastic surgery residency. I also did a year of a fellowship and a year of research. So it's a lengthy training. And then once we're all said and done, the American Board of Plastic Surgery does some testing. It's a written examination as well as an oral examination. And they look at the cases that the surgeon is doing and things like that to make sure they meet a certain standard, which is required. And then above and beyond that, even when you're in practice, there's something called maintenance of certification, where there's a whole bunch of things that that board looks at to make sure that our surgeons are properly trained and maintain that training throughout their careers.
Is this different from a cosmetic surgery certification?
You have time for another show?
Okay, so it is, but
yeah. You are hitting on, yes, there is only one American Board of Plastic Surgery.
okay.
There's only one society, American Society of Plastic Surgeons. Board certification is unique to plastic surgery. There's no board certification in cosmetic surgery. That's approved by the American Board of Medical Specialties. Again, a longer discussion, but there are groups out there. It's nice when you're in a field where everybody wants to be, what you do. And we're fortunate in plastic surgery, a lot of people want to be plastic surgeons. So it's very important for us to uphold to the public that training, that certification, and what that means. I always tell patients, when you're looking for a doctor, do your homework. And part of that homework is if you're coming for a plastic surgery procedure, make sure you've done your homework and truly found a board certified plastic surgeon.
Can you think of, or has anyone ever lost that board certification?
Oh, sure. I mean, I can't speak to I can't speak to specific examples, but sure, there is oversight. The American Board of Plastic Surgery, as well as ASPS, has a very high ethical standard for its members, and those go to a lot of different facets of practice and education and training. I mean, I guess the easiest one is that if you don't maintain your certification, you can't stay board certified plastic surgeon, and that involves a little bit of testing, a little bit of a look into what cases you're doing and things like that. So there is oversight for sure, and we hold our members up to a very high, both ethical and clinical standard.
So is the ASPS a professional association?
Yes.
Is it a trade association?
I hate that term.
Okay,
At least
explain why.
maybe that's a personal
Okay.
hate because, I hear a trade organization, I think about going to a meeting, and there's a lot of exhibitors there, and we're kind of one of the exhibitors, and there's a lot of dealing. Sure, we do that. Absolutely. We have our annual meeting every September, October. We have a lot of partnerships in the field and marketplace of plastic surgery. So that does occur, but that's a very small portion of what we do. And that's why I think that calling it a trade organization doesn't sort of do it justice. Really, it's a professional organization that does all of the things that I mentioned, whether it's education, advocacy at times too for certain, and that includes advocating on behalf of our patients often, or looking at ethical issues, or looking at research and delving into that, much like I think we're going to talk about. That's a huge part of what we do. So when you call it a trade organization, I think personally, I know people call it that. I think it minimizes a bit what we truly do as a broader organization.
Thank you for that clarification, because in this realm, I think you're right. Some of us have used that phrase trade organization maybe a bit disparagingly, but we have, been looking at other organizations that are similar, like the American Society of like the Pediatrics Associations, the Endocrine Society. These are all very similar. Would you say that these orgs operate similar to ASPS, that there's research, ethics?
There are similar, those are similar professional organizations. Obviously, I'm not part of any of them, so I
Okay.
can't speak to the specifics. I'll give you a good analogy, though, that comes up all the time. We're physicians and surgeons, right? When I went in my training, my chair of surgery said, "You're a doctor. You earned it. Call yourself the doctor," right? And what are the insurers and what a lot of places people call us now? Providers.
Got it. Okay.
It's the same kind of sort of,
Yeah.
it's not meant derogatorily, but it kind of lumps us into this sort of, pattern of, minimizing what we've done, and the expertise that we bring to the table when it comes to clinical care. And I think it's
And I
important.
think it consumerizes it a little bit more. And
Absolutely.
consumer medicine it has its own concerns. Just a few more real basics.
No problem.
Do you think that most or all surgeons performing gender-related surgeries are board certified plastic surgeons, or you're saying that the patients need to really be aware if the surgeon that they're seeing just is calling themselves a plastic surgeon? Because in theory, they could do that, right?
This was a basic question. Okay. The answer is I can't give you hard, fast numbers, but much like the rest of plastic surgery, and there are people presenting themselves as plastic surgeons who are not board certified plastic surgeons, I believe that there are others that are doing these types of surgeries as well. There's a variety of incentives why to do it. We'll talk about at some point, but I think that yeah, I think, but it's true for general surgery, probably not as much though, because there's not that cosmetic element which you intimated earlier, that people who are doing these procedures want to be involved with. But I'm sure that there are some people that are doing these procedures that are not board certified plastic surgeons as well. But I couldn't give you a distinct number.
Okay. So let's move into what brings you and I basically to sit down and talk today. So you are no longer the president of the American Society of Plastic Surgery, but you are serving still in the role on the research side, on that side. Is that correct?
No, let me be clear because this is important because I've been fortunate. I spent 17 years on the board of the American Society of Plastic Surgeons and the Plastic Surgery Foundation. In 2015 was when I was president of the American Society of Plastic Surgeons. And in 2024, I ended my term as president of the Plastic Surgery Foundation. I remained on the board until October of 2025, which by the time I came off the board. That doesn't mean I'm not still involved. That doesn't mean I'm still not involved in the topics. And, hopefully I bring some knowledge and expertise into those issues. But I just want to clarify that because I think that's a distinction that's important. I'm sure we're going to talk about the ASP's position statement at some point. And it's important to understand when that process started, where I was in that process, and whatnot. In addition, however, I have been the co-chair of the ASPS Gender Surgery Task Force, which I'm sure we'll talk about in a bit. And that position I'm still in currently.
Okay. Let's do a little bit of timeline. So you started serving as the ASPS president in 2015.
2014 to 2015, yes.
2014 to 2015. Okay. Were gender-related procedures on your radar at the time?
Not really. I mean, on my radar, sure. Were they happening? Sure. Would I go maybe to an educational program and hear about it? Sure. I remember distinctly one of my good friends in New York City, older than me, a mentor even, was doing these types of procedures, but it wasn't on radar to the numbers that we're talking about now, or to the sort of front and center dynamic with regards to our educational discussions. It was sort of happening there. There's plenty of, niche procedures we do in plastic surgery, which we don't talk about a lot, but they're happening. That's sort of where it was. That dynamic changed, probably in the late, teens, 17, 18, 19 timeframe. And we saw a huge growth in these procedures in adolescents and in adults during that time. One could ask why. Were there more gender dysphoric patients? I don't know the answer to that. I don't think anybody can answer that. Can I tell you for sure that I've seen social media play into it and things like that? Sure. I can tell you on a personal level, I know patients, both in my practice, sons and daughters of some of my patients, even who were going through some of these things. A lot of them followed the natural course of what I believe is either gender dysphoria or thinking they're gender dysphoric. And it just sort of played out through their adolescence and then it went away. I think we'll talk more about that as well. But definitely in the late teens, there was a growth of these procedures going on, of the talk of gender dysphoria going on, no question.
Okay. So you were following what was happening internationally. And so at some point, you became aware that in the UK, Baroness Hilary Cass, I believe she's a baroness now, was commissioned to complete an overview of what the Tavistock and the NIH, what they were providing for minors. And she eventually put out two reports, the interim CAS report and then the final version of the CAS report. Do you remember seeing that final version and what happened when that came about? You read it?
Sure. So there's a lot to that. Let me just clarify one thing. Even though these procedures were happening in that 2014-15 timeframe, I think I was aware, others were aware that in European countries, especially the Scandinavian countries, this type of surgery was taking off. This type of care was taking off. And so there was that background knowledge of that. At that point in time, ASPS, for example, was growing into the global market. We probably started growing the global market in the 2010 timeframe, and that really took off at the time, I was president and after. With regard to the CAS report, obviously I knew that she was commissioned when it was happening because I was following this topic. I saw the initial report. I saw the final report. I've spoken to Hilary Cass. I've invited her to be on a panel that I had organized in October 2024 at the annual meeting. I'm sure we'll probably touch on that because that is sort of the generation of how we got to a gender surgery task force at ASPS. So sure, I was following that. We at ASPS were following the science, the data, and the evidence behind gender affirming surgeries for a while, though. Before that, we had sort of contemplated, should we have a guidelines here? We were kind of trying to figure out where the evidence was, and we in late 2023, early 2024, we were realizing that the evidence and data and science in this area is of low quality and low certainty. And that is why, maybe I'm jumping ahead here, I don't want to jump ahead too much, but in August of 2024, ASPS came out with a position statement cautioning our members about doing these surgeries in children, adolescents, and minors. And the reason is because everything we saw was telling us that the data and evidence was of low quality, low certainty. And if you put the CAS report out there, although it was only endocrine that she looked at, it was clear that, this was falling on gender affirming surgery as well. And so that was sort of a reaffirmation for us, no pun intended, that we were right in terms of our assessment of the evidence and data up until that point. And then since then, more has happened in other releases and whatnot.
Okay, so I have two questions here. I do want to know what happened because I don't believe Hillary Cass ever spoke at your conference.
She did not, unfortunately.
Before the gender task force gets set up, was there ever an LGBTQIA plus working group or member group within the ASPS?
Sure.
Okay.
It has changed its iteration over the years, but that's been in existence for a long time. We reference it sometimes as the Pride Committee, but there has always been, different facets of society that have been formed as a group. I wouldn't call it a task force per se, but it had been formed as a committee and whatnot. We've changed our governance a bit, and so now there are special interest groups as part of that governance. So there's a special interest group for that as well. And so, yeah, that's always been a part of the society. I'll be honest, okay? I've never really linked the two. I don't think the position statement that we took about gender affirming surgery or that position was necessarily linked to the Pride Committee or anything like that when we took that position. I do think that there were elements that weighed in on it, sure, and people had their opinions. But there was other committees, such as the Guidelines Committee or the Patient Safety Committee that would weigh in as well. I think that when we looked at this sort of independently from some of those other things.
So I ask about the LGBTQ or the Pride
Mhm.
Committee because in some of these other societies, we have heard that it was pressure or individuals from that kind of working group that would claim kind of ownership over the gender related guidelines or claim that they were the specialty providers. But in the ASPS, what was kind of the goal of the Pride Committee? Was it for providers who identified within that community to find camaraderie and find other providers to interact with?
The beauty of some of our committees is they set their own agenda, right? So I couldn't tell you exactly at that point in time where that committee was thinking. Maybe they were dealing with some advocacy issues. Maybe they were doing networking. It's just, the beauty of our society, and much like the beauty of the way our policy statements come up, is everybody weighs in at different points in time. Ultimately, though, it's the board's decision to come out with a policy statement. I mentioned August 2024. That was, an ASPS board decision to come out with that position statement and to sort of caution our members. So there's not, there's no group, at least at ASPS, and I think, that's important, is given the role of setting policy for society. That is strictly and ultimately a board decision, board position.
Okay, so let's talk about the panel that Dr. or Baroness Cass was invited to. What conference was this supposed to be for?
So every year we have our annual meeting for ASPS and PSF, and we call it PSTM, Plastic Surgery, the meeting.
The meeting.
Right, exactly.
Okay. Okay.
It's got a nice brand to it. And so we take that, in different cities every year. This one was going to be in San Diego. As part of that meeting, each of the presidents, the ASPS president and the PSF president, which was me, are able to set up a panel that they want to do.
Okay.
For me personally, I can give you a little background.
Sure.
I'm probably only the second private practice plastic surgeon to be president of the Plastic Surgery Foundation. Private practice plastic surgeons are not necessarily known for research and things like that. With that in mind, as I made my way up the Plastic Surgery Foundation ranks over those ensuing years, the previous years, I became very interested in the whole topic of evidence-based medicine, evidence-based surgery, methodologies as to how we get to that. Patient safety has always been a huge part of, I lecture on that. I've been lecturing on that for 20 plus years.
Okay.
I'm only in practice 25, so for fairly my entire career. But this evidence portion, I really wanted to get to hone in on. And I felt I owed it to people that were honoring me by putting me in position of leadership to really make that a part of my bailiwick. And so with that in mind, as my presidency was culminating, I said, let's make the PSF President's Panel about just that. Let's do a panel on methodologies to determine evidence in science. And with gender surgery as the background. Nothing further. That was it. And I thought I had, was providing a fair and balanced panel. I invited a methodologist, someone who ended up being on our gender surgery task force. I invited a lead gender surgeon to be on the panel, and I invited Hillary Cass. I never thought she would accept, and she did. And she was quite, quite nice about the whole thing, and spoke to me multiple times on the phone. I got to, learn a little bit about her background, which I didn't really know in depth. I got to speak to her and really get her views in depth, and it was interesting and enlightening, educational for me as a surgeon to be able to hear that. I figured, why not share that with everybody else in the plastic surgery world?
So did you know going into this that there would be a controversy of your recommendation? Or it sounds like you were like, hey, this is a current international topic. Let's talk about it.
If I'm honest, yeah, I was somewhat taken by surprise. I knew it was a hot topic, but
Okay.
that's usually what we try to do with these panels is make them on hot topics. I'm known for taking on hot topics. And if you ask about me and what I like to speak about, but I did make every effort to try and make it fair and balanced, as
Okay.
I just told you. And then once it was sort of out in the public domain, it took on a life of its own, and people started to complain, and people started
Let
to
me let
say,
me slow you down for a minute.
okay,
Was there
sure.
another conference
I was
scheduled
about,
to
yes,
occur at the same time in Lisbon?
yes, I was about to get to that.
Okay, go ahead.
So there was the WPATH conference in Lisbon going on. So a lot of the gender surgeons were there, and one of the complaints that they wouldn't be able to participate. So I went out of my way to set up a remote link so that they would be able to watch the panel. And the gender surgeon who I had on the group, it was unclear whether he was going to fly back or he was going to stay there and participate remotely. But we offered up all of those links and opportunities to participate.
And what happened?
Well, a lot of resistance, a lot of complaints, eventually a petition, and I admittedly decided to postpone it.
Okay.
And I emphasize the word postpone and not cancel because I think that's important as to how the gender surgery task force became, part of that decision to postpone.
Okay.
It was part of the decision.
So you postpone this panel and you politely tell Baroness Cass, thank you so much. We hope to have you in the future. And a task force gets set up. What was the purpose of the task force? Was it to address the controversy and the hard feelings? Was it to smooth that over? What was its goal?
In some ways, it was all of the above, but let me distinctly tell you what I thought and what I believe was the purpose. Okay. Number one, it was to see if we can come to a panel that everyone would agree to could happen. And
Okay.
although we didn't have a meeting coming up per se, maybe do it on a webinar or something like that. So an educational component was clearly the initial mission. The other mission is to bring people together, surgeons, non-surgeons in the space who brought differing views, differing expertise to see if we can build consensus. My experience in other areas, I'm part of a large breast surgery collaborative community, which is another consensus building body, different topic. It's breast surgery and breast implants, which are known to be controversial at times. And we had a very successful time building consensus in that group. My hope was that, hey, we could do the same thing. It took us a while to get the group set up because we came up with a process where whoever we invited to be on the task force everybody would have to agree to them. And so you can imagine that took some time, but we got there and we managed to get a group together with differing views, different expertise, gender surgeons, psychiatrists, methodologists, myself who doesn't do that surgery. And the goal was, is there a way to build consensus?
Okay. So just to be clear, this was not set out with a purpose of writing the guidance for the ASPS or the guideline, or this was not the guideline committee to write.
Absolutely not. And just hone in on that point. We had people that weren't even ASPS members on this task force.
Yeah. Yes.
And that was done purposely to bring different perspectives. But I think it's important to also acknowledge that when we started, I remember vividly the first meeting, my saying to everyone that, this is an opportunity for us to talk about these topics and see if there's an opportunity to build some kind of consensus. We even gave the first two meetings up to two people, one a gender surgeon, one a psychiatrist, to literally lecture the group on their perspectives on gender affirming care. It went to adolescents and children. We didn't really start there. It wasn't the intent to start there, but it went there naturally because that is the hottest of topics. And so there was an opportunity. Now, at some point, and I don't want to get into the details. I can't get into the details of the discussion because I've promised that we would keep those confidential, and I want to respect that.
Okay.
And we can talk about what's not happening.
I mean, although
right.
I believe but the psychologist who was on this task force openly published the letter on LinkedIn.
Yes.
Okay.
So we can get to that in a minute, but let me just finish this thought because I think it's important. At some point, there was discussions about, because we were not finding consensus, how do we get there? Do we redefine the mission? Do we redefine the goals? And so there was talk about that. But we never, after 9 months of meetings, we're never close to consensus.
Monthly? Were you meeting once a month?
Once a month.
So the first 2 months are basically given to the affirmation side. You may lecture us.
Yes.
Okay. But you're saying after 9 months, there was not any real evidence that consensus was possible. Can I ask this without going into who said what or when? Did it seem like those who came to the task force with a WPATH specific background, either they were writing chapters for WPATH or were longtime WPATH members, were they engaging with the evidence? Were they saying were they at least open to have the consideration that the evidence was low quality or not there to support interventions?
Yeah, I don't want to get into the specific because it is known who's on the task force, and I do want to respect them. I'm happy to have that discussion as to what's happening outside the task force because I believe, similar things are happening outside the domain of the task force. And so we can have that discussion, absolutely.
Is this spilled out a little bit publicly?
Yes, absolutely. I also want to say that, the arguments for gender affirming surgery in adolescents and children in general have changed, right? I've watched them go from first being, we're saving lives, we're preventing suicides and things like that, to an acknowledgement that maybe that wasn't happening, to then being told that, well, my expertise and my experience doing these surgeries, for example, should trump all else. And that really didn't cut it because we made the arguments that if you're truly following methodologies, the methodologies to get you to the guideline, to the evidence, need to somewhat be unbiased and unconflicted. And so then the next argument ends up being, well, no other surgery in plastic surgery undergoes this type of scrutiny. And, I would half agree with that and half not. And the examples that have been thrown out there, breast reduction in a 16-year-old or a rhinoplasty, say, in a 16 or 17-year-old. And let me take them one by one. If you look at the data, evidence, and science behind breast reductions in 16-year-olds, there is a wealth of evidence supporting that it can relieve back, neck, and shoulder pain. There's a wealth of evidence showing that for children, who can be bullied, that there is psychosocial benefits. But no one is being promised that it's going to save their life. Okay. No one is being promised that it's going to help them really their mental health. And that goes for a rhinoplasty as well. We tell patients who have rhinoplasties, you're going to look different. You may feel like you look better. That's up to you. But we're going to change your form. We're not going to change, your mental health. We're not going to save your life by doing a rhinoplasty. And I think that's the difference, because when you really get into the evidence regarding gender affirming surgeries in adolescents and children, those are some of the claims that are unsupported by the evidence and the data.
I want to take you a step back for a minute, because something immediately just kind of, came forward to me as just a major concern here, which is that you're basically saying that part of the conversations, or part of this, maybe even not even the task force, but the way that gender affirming interventions are talked about in general, is that there's a life-saving, you're talking about this life-saving suicide reduction component. But what I have always understood the surgical element to be is the very last step, often, in what was initially laid out as this whole pathway, that the suicide component. It's interesting to me that you're having people say this is suicide reduction or suicide intervention when it's step Z, when step 1 was always explained to the public to be a biopsychosocial assessment, mental health treatment, engagement with the psychologists, psychiatrists. How are they making this connection to the last step being the life-saving portion? It almost feels like, were people saying you could skip the mental health and you just do the chest surgery, and that by itself is life-saving? The endocrine doesn't matter? How did they pull all of this apart?
So this is critically important to understand. It should be a graduated, algorithmic approach to the treatment of someone with gender dysphoria. I agree with you. And all of the things you pointed out are the way it should progress. But we know there are cases out there where people jump just to surgery. But all of this is tied together. And people have critiqued the ASPS statement because we mentioned the low quality of evidence and data when it comes to endocrine, right? Although we don't take a position on it because it's not our expertise, it would be foolhardy not to mention that as well, because many of the patients who get to surgery have had endocrine treatment. In fact, the vast majority have.
For a long time,
Right.
the WPATH guidelines would say you don't jump to surgery unless, chest reconstruction surgery to masculinize the chest, they would say essentially in SOC 6 or 7, you should be on testosterone for at least 12 months, because the testosterone itself is going to move the body fat around and change where things are going to be at. It seems like you're getting pressure from both sides saying you can't talk about the endocrine side and the evidence there, while at the same time, the surgeons are being asked to be the final step in a whole pathway. Don't you have to understand the whole pathway?
Absolutely. I think you do. And I think that's why, some of the comments that have been made about, well, somebody else told me, or confirmed for me the diagnosis of gender dysphoria. So that's why I went ahead and did the surgery. And I think we as surgeons, we talked so much at the beginning of this about how important training and expertise is right? It's incumbent upon us as surgeons to be part of that decision too. And if we see something that doesn't fit, to stop that process. But there's another element too. Your question is about, how does the treatment start? I would agree with the way you laid it out. It's a mental health diagnosis first, then it's, mental health therapy, whether it's psychotherapy, whatever. Then it goes to potentially hormonal endocrine therapy, and then only as a last step. Now, I don't want to misstate. I'm not saying that the vast majority of those that are coming to surgery are skipping those other elements. Quite the contrary. The vast majority are going through those steps as well. But I've seen firsthand in my practice from some of the detransitioning patients that I am treating now that they were skipped. And, looking at their medical records, it's fairly obvious. But that's not the norm. But let's go back to what is the norm and why I think it's so important, to your point, to understand the process. What is it, if there were no hormonal treatments and there were no surgeries, what would be the normal course for a child with gender dysphoria? And the answer is that, at least in my opinion, the majority of them
Will desist.
would desist, would just transition back to a normal, or whatever we want to call it, non-gender dysphoric child. Now, the real element comes in, and this is why I think it's so critically important in this vulnerable population to look at, that, because we can't predict. We cannot predict, and this is why it's so important, who it could benefit if you think it's going to benefit them, and who will not benefit, and who may regret, and who may detransition, and who may have some significant risk of complications. And that's why I think the ASPS position statement is so critical. No one's saying not do these later on, and that's a topic for a different discussion, but all that's being said is postpone to the age of 19. And we should probably spend a minute or two on why the age of 19, because I think that was an important decision as well. We can get to that. But to your point, it's a process of treating these patients. And I think that certain parts sometimes get skipped, sometimes they don't. But it's very unclear as to how do I predict if somebody, to my field, if somebody comes to surgery, how do I predict whether it's going to be a success? That is a positive risk-benefit ratio for our patients. That's what medicine and surgery is based on. Is don't do a procedure unless you can assess it to have a positive risk-benefit ratio. It's what we do every day of our lives since the day I started medical school till today in assessing what's right for a patient and what is potentially not right for a patient. And you just can't do that here because the data and evidence are just so low quality. So why not do the less risky thing and the more cautious thing, and which I believe is in the interest of patient wellness, is to not jump into something unless you're sure it's going to help them, or at least have a significant base of evidence to show that it will help them.
Okay, I have so many thoughts right now. One thought about where the surgeons land kind of in this pathway of making the assessment, is this going to be beneficial or harmful? I think you're right. If we just look at the systematic reviews of evidence, how many good quality studies there are out there versus low quality, I think you're absolutely right. For the most part, we cannot make a quality determination who will benefit but who will be harmed. But in the recent detransitioner lawsuit that happened in upstate New York, I believe that when it came to the determination of who was fiscally at fault, most of the burden was placed on the assessing mental health professional. I think it was a 70%, 30% split, that they shared 70% of the burden for the negative outcome, and the surgeon shouldered about 30%. Are there other surgeries in plastic surgery that are routinely being performed that are so heavily reliant upon this cooperation or determination by a mental health provider?
The simple answer is no, but it's much more complicated than that. And let me break it down. First of all, let me preface this by saying I don't know that case. I know elements of it. I don't know it. I'm not an attorney. I can't speak to the legal elements. But there were elements of that case that were based in body dysmorphic disorder.
Yes.
A way different element than gender dysphoria. And body dysmorphic disorder for surgeons is a hard stop. You don't operate on somebody with body dysmorphic disorder, even if there's a psychiatrist or psychologist willing to say, go ahead and do the surgery. Why? Because, you know, it's one of these basic things we learn in plastic surgery. We want patients to be doing these surgeries for the right thing. You know, we are humbled in my profession. We operate sometimes on people that are quote unquote normal, and we put a scalpel to them and we change things. And we want to make sure that these individuals are doing things for the right reason. So if somebody comes in and tells me, yeah, I'm doing this because my boyfriend said he wants me to do it, that's a hard stop. Somebody comes, often, you know, I hate it when patients come in and say, I want to look like this celebrity. To me, their expectations are not real. That may not be a hard stop, but it's pretty close there. And so somebody with body dysmorphic disorder who's been diagnosed, who doesn't have a good sense of body and self, that's the last person you want to operate on, right? And so, you know, that case got a little bit confusing because of that element there. But to answer your question, there's rarely a procedure that I do as a plastic surgeon, that we do in the plastic surgery community, that is so dependent upon a psychiatric evaluation. Does that mean that there aren't patients that I don't suggest should have a psychiatric evaluation perhaps before, and, you know, we depend upon it? Sure, that happens not infrequently, not a lot, but not infrequently. But that's the surgeon assessing, hey, there's something I'm feeling, you know, here that just doesn't seem right, and I need another expert to help me through this. Nothing wrong with that. Just like I might call a general surgery colleague to help me with a procedure, just like I might call a neurosurgeon to help me with a procedure. We each have our expertise, and, you know, that's way different than sort of setting the standard in advance that they need to come with a certificate of psychiatric or psychological evaluation. And then all of a sudden, that's a free pass to this type of surgery. That is something that you're correct is not, there's something just not the norm about that.
I would assume that if you're surgically operating on an individual, the norm would be you're making sure they're cleared from a cardiac level, or that their lungs are okay, or that they don't have an issue that would be physically challenging to be put under anesthesia, or those kinds of things. I would assume standard of care is you're clearing those elements.
Absolutely, all the time.
Okay, let's go back to the task force for a minute. So you're about 9 months in. Had you hit a wall? Do you feel like you personally are on this task force? Do you feel like you hit a wall?
Look, I'd be lying if I didn't say there was a certain sense of frustration. As I mentioned, I'm involved with other consensus building coalitions, communities, and I've always seen the ball moving forward. And it really wasn't happening here, at least to any kind of degree that I thought we were making significant progress. But let's take it back a step, because I think this is important to know. Because there has been this, you kind of suggested it earlier, that somehow the task force should have been the one, you know, making the policy. That was never the case. But more importantly, I did argue that when it was clear that this statement was coming out, that we should show it to the Gender Surgery Task Force in advance.
Okay.
And the general counsel from ASPS said we couldn't do that. That's in the public domain. You know, there's an email to that effect. That I think I have to make public, because it's being misconstrued in that open letter, and in other places they call out one portion of the letter. And, you know, it just makes sense, right? There was just too many conflicts on this group, right? There were, you know, members of the board of WPATH. There were some people that weren't even members of ASPS. So it just, you know, from an organizational standpoint, and I get it, you know, I did argue to openly, you know, to bring it to them, just to show it to them, just to give them, the acknowledgement that, you know, just as a courtesy. But we told we couldn't. And you know, it just makes sense that an organization can't possibly turn over its policymaking, you know, when there are other conflicts involved.
to outsiders with significant conflicts of interest. I mean, that's in essence what this letter was asking ASPS to do, to turn over their guideline making, decision making to non-members who have significant conflicts of interest.
Now, I appreciate, yes, yes, I do appreciate the argument that has been made that, well, we're the gender surgeons and we do these surgeries, we have an expertise. Absolutely. And all of that was taken into account into the position statements over the years. But if you do true methodologies for guidelines, do true methodologies for systematic reviews, I like to talk about the grade framework, Gordon Diet. Yep. And I think it's the quintessential sort of methodology that should be used. And if you read it carefully, there are a couple of things to it. It specifically says that, sure, you should garner expertise when necessary. But in addition, you need to make sure that you have unbiased people assessing that data and evidence as well. And they actually stress that that's the most important part of it, because you don't want the conflicts to become part of the decision making.
Okay. But for layman's terms, unbiased, these words in medicine are not just fiscal. They are about fiscal bias, but they're also about your research interests. If you've only worked in one field, this is about like bias in multiple layers, but is one of the aspects of good methodology work that you look at fiscal bias. If all of your income is driven by doing gender-related surgeries, is that a bias?
Absolutely. It doesn't mean that you can't be part of the process and offer opinion and whatnot. But obviously, just think about it. You can't be the final say. It just, anytime there's conflict, look, in my career, there have been times where I have conflicts. I work with certain organizations and, industry and whatnot. And I have to back off because I realize that certain conflicts that I bring to the table, can I weigh in? Sure. Do I weigh in? Am I allowed to weigh in? Sure. But it's limited. The same thing holds true here. But it's very difficult on a hot topic to not find people that are, may not be biased one way or the other. But that's really, what I think happened here is that, yes, there have been discussions about these topics for years, but at the end of the day, the board was the ultimate decision maker, decided to move along with this statement that it was time to silently put that down. We've had discussions about that specific, decision, again, for years. But I think the evidence and the data sort of, the evidence and data didn't evolve. I want to be careful. The evidence and data was the evidence and data. I think our understanding of the evidence and the data evolved to the point where it was just, it couldn't be ignored anymore. And again, I have to say this because as a physician and a surgeon, it's hard to somehow suggest that you're going to ignore the data and the science at all. And if you let me, I'd love to make an appeal here. If you're willing to let me do it, I've thought a lot about this, as a past president of a multitude of scientific and patient safety, medical, and specialty societies. I would love to call on my colleagues at other societies as leaders, to try to take an honest and dispassionate look at the evidence and follow the lead of ASPS, the American Society of Plastic Surgeons. And I say this with the full understanding that members of those societies are personally and even financially invested in these procedures and treatments. But again, if we truly believe, why we've become organizational leaders is we owe it to the public to put science and medical ethics and patient well-being first. So that's my appeal. And I've initially tried to maybe not make it so strongly and so pointed. But as this discussion has evolved, and the discussion has evolved, not the data and the science again, I think it's important that everybody at least has a willingness to do that and to come back to the table and say, hey, we've looked at it and this is where we landed. I just find it, that's what we're about as physicians and surgeons, not as plastic surgeons, but as physicians and surgeons. When we take that oath, right, that Hippocratic oath, which, may sound trite because we refer to it all the time, that's really what we're doing. We're making an oath to do what's in the best interest of our patients.
I hope that you have some of those other societies' leadership contact info, and we'll follow up with them, because I believe it is the thing we need from leadership right now is to step up and lead. You're absolutely right. That's why they're in this position.
And without revealing any names or societies, I can tell you they found me. They found my contact info. And some of these groups have actually reached out to me. And because there are pressures, they've sort of asked me, well, how do you do this? And I've tried to guide them the best I can. I don't know their organizations well. But they have said, how do I do this? How do I convince the other people that are giving me resistance that that's the best path forward? And I just reiterate sort of the journey may be a bad word, but the progress and the way we've looked at the science and data at ASPS, and I've reiterated to them to just go back and try to do the same thing.
Okay, let me ask this one. So ASPS put out your recommendation.
Correct.
Are you expecting, or is there an expectation now that your members follow that?
It's a great question. The simple answer would be yes, but we don't dictate clinical care. Okay, we're a professional society. We make recommendations. We are not standing on over people's shoulders. There are tons of other elements here as well, and we mention these in the statement. And first and foremost, we do not, despite whatever is said, we don't believe in the criminalization of care. We believe that we're scientists and surgeons, and that we should get there through clinical decision-making, evidence-based clinical decision-making. There are also multiple states, about half of them now, maybe more, that now have some type of ban or law that makes it illegal. And so we caution our members in the statement to be careful and know what's going on in the state where you're providing this care, if you're providing this care. Sure, the expectation is, I would love to think that, everybody's going to follow this guideline, but I'm also a realist. I think it was Ronald Reagan who said, if everybody likes me, right? Maybe it's the wrong quote for
Go for it. Quote him.
Is that, if everybody likes what I'm doing, then I'm probably doing the wrong thing.
Yes.
And so there's a full realization that there are going to be differing of opinions, different assessments. But I hope people realize that at ASPS, and me myself really feel we are doing the right thing based on the evidence and science.
Okay. So beyond the membership, do you think or see or expect that there will be insurance companies or, say, hospital risk management or ethics boards who will point to this statement and say, we're not going to cover this anymore, or no, we're no longer going to schedule these procedures in our suites?
So if you have another hour, we could talk about the insurance elements around gender affirming surgery, because I think there's a lot there. I heard somebody
But
recently.
have you heard anybody saying?
Well, all you have to do is look at the news, but the news is portraying it, as pressure from the administration to cut off funds, and that's why they're doing it. I'd love to think, and maybe I'm too much of an idealist in this sense, that they're doing it because they're looking at the evidence and data and science, or they're following leads like the American Society of Plastic Surgeons. I will tell you, the one thing that I was thrilled to see was about 2 days later, the American Medical Association,
AMA, yes,
in the National Review quoted as saying, and I'm paraphrasing here, that, because the data is of low evidence, that they are following the lead in recognizing the position statement of the American Society of Plastic Surgeons when it comes to gender affirming surgery. Now, there were a couple of equivocations in the statement with words that I probably wouldn't use, but hey, to me, that's the step forward, right? And to what my statement earlier, I wish other organizations would do the same and come out with at least similar statements, if not going that extra step.
Okay. I think I have 3 questions left.
No problem.
One is going to go back to the task force. Has it been disbanded? Is it set to meet again? Are you all still ready to talk more?
In my mind, it's still there and it will move forward.
Okay.
I'd be lying if I said we met the month after the statement was released, because we didn't. But I think that, that was sort of a cooling off period, for lack of a better way of saying it. I am hopeful that next month we are able to meet. I am willing to meet. Whether others are, I can't speak to that. And so, time will tell. But it has not been disbanded officially. It has not been disbanded at all. And so the goal is to keep moving forward.
I commend you for your willingness to remain engaged in the room.
If you listen to what I said, I truly believe it.
Yeah.
Anybody who knows me as a surgeon will tell you that Scott Glasberg likes to engage, and even doesn't walk away from even a conflict. Right? We are much better off if we are talking to each other than talking past each other. I truly believe that, and I have seen this now in a variety of areas of healthcare and plastic surgery, where I have engaged and I've been shockingly able to come to consensus. I mentioned the breast surgery collaborative community. Maybe we'll have another show one day and I can explain to you about that, or another interview. That's been a great example of where I think we've been able to build consensus. And so I'm a believer. Maybe I'm too idealistic. I do like to call myself a realist at most times, but maybe I'm just too idealistic in thinking that we're better off continuing to discuss the topic, acknowledging that we may agree to disagree. But, some of the heat from those conversations, I think gets taken away if you're still at the table having a conversation.
Okay. You're willing to meet. As far as you know, the task force has not been disbanded. I have heard and from no, source, but just this idea out there that there might be a split, that the ASPS might have a group that is willing to split off over this or leave their membership over this. I think we saw something happen with the American Academy of Pediatrics years back. There was a split, and we saw 2 orgs basically form while the American Academy of Pediatrics stayed in the level of kind of, the prestigious one. Do you have any worry that this is going to lead to a split, or that people will pull their membership and try to start something else?
So if I still had a board hat on, of course I'd be, and of course, as without a board hat, of course I'm concerned about that. Nobody has per se threatened that yet, thankfully, but that's always a concern. I mean, any professional organization is always concerned about attrition of their members for whatever reason, and concerned in continuing to provide them value. I hope that one issue doesn't become the line in the sand for ASPS with regard to these surgeons. We provide so much more value beyond this one topic. But anybody who thinks you're going to, join an organization and agree with 100% of what they say is not being realistic. That's the unfortunate truth. And so my hope is that we will continue to engage in discussion. Look, we'll continue to look at the evidence and data. It doesn't look right now that anything is changing in the near future. But if it does, I think we all have open minds and are willing to engage on evidence and data at any point in time. And so the answer to your question, the simple answer to your question is, sure, I'd be lying if I said that wasn't a concern. But by the same token, I hope that one topic doesn't become that type of line in the sand with regards to membership, and that there's a willingness to continue to discuss. And, again, with my ASPS hat on, having spent 17 years on the board, I hope that people realize that ASPS is much more than one single position statement, and that we provide a ton more value to our members, in this case, to the public, and to our patients. And we owe it to our patients to continue upon that path. I'm very proud of the time I spent involved with ASPS, and I'll, look in different ways to stay engaged with ASPS in the future. And I am, and so I don't mean to make this a commercial for ASPS, but ASPS is a valuable entity when it comes to plastic surgery, both in the United States and globally.
Okay, so my final question is going to kind of have a couple layers to it. So I'm going to let me frame it up for you a little bit. So the position statement comes out, and we saw a couple hundred surgeons or affiliated individuals sign kind of a petition or a document, basically, I guess, complaining about what they saw as the process. I think we've covered the process pretty well already. But one of the elements about who signed that is that it looks like about 30% were students.
Oh, I see what you're saying.
And these are individuals who are still in those kind of final stages of their surgical training. And we can assume, I think for the most part, we could assume they're younger than you and I. They're in a different kind of.
Definitely me. I don't know about you, but definitely.
I'm Gen X. I'm right on the cusp of Gen X. Are you concerned, or have you thought about that the training itself, that the way new doctors are being trained, that the kind of cultural, conditions that these new doctors are in have already changed their way of thinking about evidence-based medicine versus consumer medicine versus even just identity politics? Are you concerned as like a leader, an older leader, that so many of the people signing this and so many people opposed to this evidence-based statement are younger providers?
First of all, you called me older there, so I guess.
I'm putting you and I in the same group.
I'm kidding. Let me break down a few things, because I do want to clarify one thing. I've looked at the signatories, but I can't tell you I've broken it down as to who's what level, in their career. I don't think there are many students on there. I think what you're referring to is there are a lot of residents in training.
So I'll say this, when we search names through NPI, through the NPI database, the three hits were either they were plastic and reconstructive surgeons, plastic surgeons, or NPI had them listed as some kind of student still.
Right. So we usually don't get NPIs until we become residents. I don't think students actually have NPIs. It's that level, it's that next level after medical school.
Yeah.
Granted, they're still in training. But I think you raise a tremendous point. Okay. Am I concerned? Again, this may be my idealist speaking again. Yeah, I have some concerns, sure. But, if we have taught residents correctly in our field, and in any field, is that being in practice as a surgeon is a lifelong learning experience. There are things I do vastly differently today than when I started in practice. In fact, I love to quote my chair of surgery. He had a lot of great quotes. And he said a couple of things.
Reagan too, or
no, he was probably on the other side of the fence, but
okay.
He said two quote things to me. One's just kind of funny, and the other is very true. He said, "Scott, what you don't know fills textbooks." And to this day, that couldn't be a truer statement. Okay. He also said to me, the day that you stop learning and changing in your practice that's the time for you to retire. And it's true. So we are all learning new things as we progress in our careers. We are all changing all the time. I don't want to be that cynical to think that somebody learns something in their residency and can never change. No, maybe they don't need to change, but I do think that they need to. One thing we need to teach, and I believe we teach, is to keep an open mind, right? Keep an open mind to innovation, keep an open mind to new procedures. Most importantly, and I think this is a good place, to where you've taken it, keep an open mind when it comes to the science and the data and the evidence. And
Absolutely.
I can tell you, I don't on the spot name them for you. There have been things in my career that I thought, wow, this is the way things should be done. And then the data changed and I changed. And there's one surgeon on our task force who has spoken up publicly. He wrote a letter to the board because he was initial signatory on the open letter and then pulled his name off, that the data and evidence changed his practices. So I am a believer of what I think is the real essence of being a surgeon, why I'm proud to be a surgeon. I actually spoke about part of this in my address to when I spoke at that annual meeting in 2024. That I think that we all change and keep open minds and learn as we progress through our careers.
I think that's an excellent place to stop. Scott, I think that this story is not over.
No question.
Okay, so I think we will keep in touch, and
Absolutely.
when we might see some more progression here, or even see if any of the other societies have some other statements in the future, we would love to have you come back.
Thank you so much for having me. I appreciate the discussion, and I'm happy to come back anytime you want me.
Perfect. Thank you so much.
Have a good day.
Thank you for joining us for this week's Informed Dissent. I want to leave you this week with something that's been sitting with me since I finished recording with Scott almost a week and a half ago. We spent a lot of time today with names, a lot of names, task force members, open letter signatories, program directors, committee chairs, people with titles and credentials, institutional affiliations that will mean very little to most people listening to this or thinking about this 10 years from now. And I keep thinking, this must be what a history book actually looks like before it's edited, before someone decides who gets to make the final cut. History books are full of these lists of names at the very beginning that might be part of some of the early chapters, but seem to disappear by the end. And this is not me trying to be cynical. I just feel like this is how the world works. Most of the people who are participating in this moment don't get to define it, but some do. Mr. Rogers, bless his heart, used to tell children and tell parents to tell children, when something is scary is happening, if there's a disaster, when the world feels like it's on fire, look for the helpers. You will always find people who are running towards the emergency. That's how you know who they are, not by what they say, but which direction they're moving. Dr. Scot Glasberg ran towards this. When a panel on evidence was quietly pulled at his professional conference, he noticed. He thought about it. When a wall of institutional consensus needed someone on the inside willing to try to ask questions in really uncomfortable rooms, he was there. He's not the loudest voice in the story, but he's one of those people who decided to move in the right direction when it cost so many of us something to do so. This was never going to be about one clinic. It was never going to be about one rogue doctor who went astray. It was an entire field. And that means the reckoning is coming within the field. And all of these players, from people like Dr. Glasberg, who is willing to stop and pause and look honestly at the evidence and say, this is not good enough. Our patients deserve better than this. So I hope you come away from this episode not thinking, oh, I'll never remember all of these names, or trying to piece together this in some sort of historical sense. I hope that this episode gives you a sense of the scale of what happened, the scale and the number of players, and the scale of what it's going to continue to take to correct it. So I thank Dr. Scott for joining me, and I always thank Lauren and Corey, my co-hosts, my colleagues, and all of the people who make this show what it is every single week. I also want to thank the volunteers of the LGBT Courage Coalition and our writing team and our editing team. They work quietly and faithfully so that this conversation can keep going. If this show matters to you, if it matters to you that there's somebody out there doing deep dives with the people, the helpers who are running towards the catastrophe, then like it, share it, subscribe to it, put it in front of someone who needs to hear it. That's how this work reaches the people that it's meant to reach. And so, as always, until next week, stay informed and ready to dissent. Thank you.